All right, good afternoon, everyone. Welcome to the ePrescribing Masterclass on the 6th of March. We're just going to wait for a couple of minutes to give people an opportunity to join. Just conscious that everyone will probably be rushing around wherever they are, just trying to join. So just to give them a minute or so just to have that opportunity. Okay, we'll make a start. Once again, just want to say thank you to everyone for joining today. I appreciate everyone's busy with all the work ongoing, but welcome to the Masterclass today from the prescribing work that's been carrying on across the country. Usually we have Hoyan and Amina, who are clinical fellows, who are, I guess you could say, that they're Ant and Dec of the pharmacy world, always looking after this session very well. So they're actually busy today, so they've asked myself and Paul to step in. So we'll be hosting you today. So my name is Shazad Ali. I'm the clinical lead within the digital medicines program. So I work 4 days a week with NHS England, and then I work 1 day a week at Manchester Foundation Trust. And as we've always said in the past, with regards to the prescribing masterclass, we always want to encourage discussion and engagement. So would welcome any questions, any points of view in the chat. So this is all about making sure that we all learn from one another, all the great work that's happening across the country, and able to kind of advertise that to everyone and share those lessons learned with everyone. And that's exactly one of the reasons why we put this one up today. And then also, there's going to be always giving people opportunity to present on the topics. If you've done something that's been think will be beneficial for people across the country, or even if you're not sure, just feel free to just reach out and let us know, because we'd love to hear the work that you guys are doing across the country. I'm sure it'll be an invaluable source of information for everyone else as well. Because if you're doing it, it's worked well, or you've had challenges, again, anything like that will be really beneficial. And also any topics maybe you'd like to see in the future as well. With that, I'll just hand over to my co-host, Paul.
Thanks, Shazad. Good afternoon, everyone. Thanks for joining the session today. So I'm Paul Wright. I'm also a pharmacist by background. I currently work within pharmacy terminology within NHS England, and I have been on previous masterclasses myself just to give people an update on changes we've been making in the terminology area. So we'll move on to the agenda today. So people may be aware that Ramandeep Kaur was down on the agenda to talk today, but unfortunately, due to last minute unforeseen circumstances, Ramandeep's had to prioritise other work today and is unable to join and take a session. But we will be working with Ramandeep to try and get her back on a future masterclass. So that leaves us with one topic for discussion today, which is valproate safety for women of childbearing age, which Shazad, Lily, and Tony are going to present on today. So I'll hand back to you, Shazad, to get going with that.
Thanks, Paul. Did you want to just mention about the community of practice as well, or are you going to do that a bit later?
Yeah, I was going to mention that at the end, Shazad. Yeah.
Okay, that's fine. Thank you very much. Okay, so myself, Liliana, and Tony have been on some really interesting work recently about valproate, which is a really hot topic. But I'm going to let Tony and Liliana kind of come in and explain a bit more about this, and I'm going to hand it over to them. So Tony, do you want to go ahead?
Thank you very much, Sad. Very pleased to be here today to talk about the potential for e-prescribing in place of valproate and keeping their babies safe from harm should they become pregnant whilst taking valproate. Can I have the next slide, please? Valproate medicines are used for epilepsy and bipolar. They are very effective medicines for epilepsy and bipolar, and in fact are life-saving for both patients with epilepsy and bipolar. Epilepsy has a risk of sudden unexpected death, which is reduced by valproate, and in bipolar, valproate reduces the number of patients who take their own life. So this is an important drug and part of our therapeutic options when prescribing patients with epilepsy and bipolar. But valproate is well known to be highly toxic to unborn children of the mothers who take valproate. And in fact, the risks are very high indeed. For every 2 out of every 5 babies born to a mum who takes valproate at any point during the pregnancy, they can be severely disabled, with a smaller proportion of those being physically disabled, like spina bifida or facial or limb malformation, or have cognitive impairment, which can affect their learning ability or their movement. So 2 out of every 5 is a very high level of risk. And so we have in place a pregnancy prevention program for those women who valproate really is the only option for them. Now, the pregnancy prevention program requires them to be on highly effective contraception. That's normally a coil or an implant rather than oral contraception. And we look after our patients by seeing them at least once a year, or at least that is the intention, to make sure that they nothing has changed in their lives, that they're still comfortable with the balance of risk that they're taking, and don't want to see a change because, for instance, they want to start a family. We require our clinicians to provide a safety net, and that is pretty much everywhere where the patient makes contact with us. And we've formulated some particular documentation called the annual risk acknowledgement form, which must be completed every year, which is really a way of recording that we've done everything that we're supposed to have done to support the patient. Can I have the next slide, please? But the patient journey for patients with valproate or bipolar, or perhaps some both, is pretty complicated. They spend most of their time in the center of this diagram in their families and in their communities, the most important thing to them. They will interact with their communities, their friends, and the internet, of course, all social media on a regular basis. Many of them will come across some charitable groups who are there to support. And then when it comes to healthcare, of course, they'll see their general practice regularly. Patients with epilepsy and bipolar frequently have other conditions that they need looking after as well. They'll of course pick up their medicines regularly from the community pharmacy. They will have access to contraception and sexual health services. Someone has got to make sure that they have highly effective contraception. In many cases, that will be the GP providing holistic care for the patient, but patients can choose to go anywhere for their contraception and sexual health services. That includes community pharmacy and includes community services. Patients do come to have exacerbations of their conditions, at which point they might come in contact with the ambulance service. And of course, we've got mental health acute providers who will see the patients, but on a less frequent basis. Our problem is that all of these patients need to know about the patient is taking valproate, what the patient is taking it for, who's looking after the patient at each part of the process, and whether or not the patient is effectively protected by a pregnancy prevention program. Next slide, please. So after a lot of work understanding our problem, or understanding the concerns that were in the system, what people had highlighted for us that they really wanted a digital solution, some way of making sure that the information was available to all the people who had to care for the patient at any part of their patient journey. We also wanted to see the patient empowered so that they could take control of their care if they so wished, thinking about their choices about contraception and their choices about their family life and how that affects their medication. we wanted to make sure that every clinician was informed of the stuff that they needed to know in order to make good decisions at every part of the pathway. And we also needed to make sure that the documentation, particularly that acknowledgement of risk form, was effectively completed. So that's the nature of what we're trying to achieve. And the next slide, please. And so we reached out for help and support in this, and I'm now going to hand over to, I should know this straight away, but I think it's Liliana.
Yes.
Hey.
Thank you, Tom. So you will maybe ask why user-centered design and why services design. Can we move into the next slide, please? So to understand that, we really need to understand what the definition of service is, and is defined by Vargo and Losch. That's one of the most quoted definitions of services as the application of specialized knowledge and skills through process and performances for the benefits of an other entity or the entity itself. Next slide, please. So then, no, before Sarah, please. So then services design, in other hand, is a practice of designing services. It uses an holistic and highly collaborative approach to generate value for both the service user and the service provider through the service life cycle. This definition comes from Services Design Network. But then services, what's user-centered design then? Is something that in the NHS England and coming from the NHS Digital is an iterative process in which designers and other stakeholders focus on the users and the needs in each phase of the design process. User-centered design gives us a set of tools, a set of skills as well that make us focus in what the users need and how can we actually engage them as well. The way I see this is the services designer basically is like a conductor of an orchestra that directs a musical performance where all the elements of the service work at once to provide a great user experience. Next. So the issue with valprate, we really were a group of different, a group of people with different expertises. So we have, they did have a big issue in hands. So what we wanted to do with using user-centered design was empower them with certain set of tools and as a place to facilitate that process of understanding the problem, and also with some tools from services design that make us visualize much better the situation that we were in hand, that we had in hand. Next. Now I'm passing to Shazad.
Thanks, Liliana. So yeah, so as we've just recapped, so Tony, as part of the patient safety team, had a question and a concern being raised to him about valproate usage, and then we needed to understand exactly what that was. So that's where the kind of subject matter expertise and also the user-centered design come in. And from an informatics perspective, I guess we need to understand what exactly does that mean. So in terms of informatics, there's a few definitions, but in terms of the one that we've had more recently, from the NHS careers, we'll display that and then see if we can understand what that means and translate it. Next slide, please, Abby and Sarah. Thank you. So it's currently defined within NHS careers as an area of healthcare science responsible for developing and improving methods for acquiring, storing, organizing, and analyzing biological data that supports the delivery of patient care. So that's quite a large piece of information within that sentence. So let's try and unpick that a little bit. So what does that actually mean in reality, and why is clinical informatics important? Next slide, please. Yeah, so working in clinical informatics, the amount of times I've been asked, you work in IT, don't you? Can you fix my mouse? Because it doesn't seem to be working. And the amount of times I've had to say, no, I'm not IT, we're informatics. We don't fix computers, we don't fix hardware. There are people who do that. Service desk, please call them. They'll probably tell you to turn computer on and off. So those are things that we can help a little bit, but that's not our area of expertise. So we have experts for that. So what we are is something a little bit different. So just move on to the next slide, please. Thank you. So what we do is we translate what the clinical requirements are and the capability between different systems and the requirements from users such as clinical staff, such as patients, and then we translate them so they're available within those healthcare systems. So we're essentially helping to bridge from the subject matter experts, the users, patients, etc., to the clinical staff, to what is actually going to be created. So having Liliana as a user-centered designer and Tony as a pharmacist as a background, you know, in the safety element, this is really, really beneficial. So that's why this example that we've been working on recently is probably, we thought we'd bring it to the ePrescribing Masterclass. So yeah, so essentially we look at what is the current process as is, if there is some, what the future state would be, and that's where we kind of create these process maps or workflows I'm sure many people are accustomed with. Another aspect we work on is making sure that it's designed correctly and we can advise it. So for example, in the past, when it comes to a pediatric implementation of electronic prescribing, we made sure that weight was mandated, and we got asked questions, why was that required? And understandably, for anyone who works in peds and neonates, everything is pretty much weight-based these days. And then the other aspect that we do fundamentally is what the impact of areas are of change on other areas is. So say, for example, we make one change within the medicines aspect, for example, that we're overseeing. That will then impact, obviously, clinicians within the doctors or the nurses or physios, because they will have patients who will have medication, and that they need to be aware of that information as well. Okay, with that, I'll hand back over to Tony. Next slide, please.
So there I am. I'm a pharmacist. I sit in the patient safety team in NHS England, and I'm faced with this large dilemma of a large group of patients who need really quite sophisticated and joined up care in order to keep them safe. But I know diddly squat about how to create a digital solution. And so it was fantastic that we had our digital safety in medicines and prescribing group, which Zad and Liliana have just referred to. Can I have the next slide, please? There was representatives there from digital medicines team, the patient safety team, my team, and also some medication safety officers who were out and about in the real world in mostly acute trusts and ICBs, who could be part of this group to help us understand, help us translate the problem as we understood it from the clinical side and delivering care to a way that we could enlist support from people who can do the design work around digital solutions. Next slide, please. So Liliana took us through a process, and I think we'll be looking at that process on a mural board to help us move from a position where we understood our problem but couldn't describe it in the right way to help people focus their attentions. And so when I showed you the diagram earlier of all the organizations and the swirly lines that go all over them, that isn't really a great design brief. What we need is something with words on a piece of paper that help people understand, well, what does that mean to them when they're designing solutions? And so the first part was to pull us together as a group of people who did understand the issues, to describe who's affected, what are they trying to do, where are they while they're trying to do it, and why are we doing it? Now, I described why we're doing it, and that has been pretty clear, that we're trying to protect unborn babies from developing physical or mental disability. So there's a clear drive for why we need to do this, and there's a clear explanation as to why we need digital solutions, because there's so much information transfer that's needed for the patient. So we described this and we captured quite a lot of people. It made us realize just how broad the requirement was. Because we knew the subject matter quite well, I'd say, we then used our expertise to think about the user stories. And so if we could just focus in on the sort of thing that we were doing, and one of those user stories. And we took a patient perspective here. And I'll read it, but one of the patient stories was they were started on epilepsy medication, had a lot of information to take in during a challenging time. They've just been diagnosed with probably a lifelong condition, and they've been told that their condition could be fatal. So at the same time, they're told that they need to take a medication. So they're unsure who to ask about the challenges of valproate and who to seek help from about their contraception. They can feel overwhelmed by the information at the time. So they ask, well, what support and mechanisms were in place? And at the same time, I'm finding it hard to contact the GP to gain information. So that's just one patient perspective that had been reflected to the people on this panel in order to bring into the topic. So that was from a clinical side as far as we could go. We described the who, what, when, and how, and the why of it, and we could describe the individual patient stories. But then we really needed help with translating that and visualizing it. And I'm just going to ask Liliana what her processes were now to go from those stories and the descriptions of who, what, where, and how into the next stage, which was part of the visualization.
Yes, thanks, Tony. But basically, to integrate the insights, the stories within the design process, what we did was to use something that we call a blueprint. So I call it, we literally co-create this service blueprint with the group, with the safety group. So then the first thing we did was moving all of the stories that are here. Everything is color coded, like patient is, the stories of the patient are here. In green are the GPs, the neurologists, the psychiatrists, they all correspond to the different stories by color. But what we did was literally just map them and then understand that as a user journey. And then with that we were able to actually create this first row of the stages and of the process. And then from that, it was a question of really between all of that, literally see it because it was visually already there, and correcting and analyzing if the things were in the right place, etc. The other thing we did was to focus in what the pain points and where the opportunities of this of this situation were, and really just like categorize them in things that we will be able to actually correct and focus on. And then this had really helped us to, and then I go back to Tony, to the problem statement that we have at then.
Thank you very much. And it really was that visualization that then helped us to describe the problem statement in a way that could be better interpreted by people who we're going to invite to help design digital solutions. This process gave some, well, first of all, it did, as Liana said, it helped us to consider our personal experiences and the personal experiences of the people who deliver the frontline care, and describe them in a structured way. So we had the tool used on the mural facilitated that so that we could visualize and better describe what we wanted from our service providers. And that is something that we would not have been able to do without the support of the clinical informatics team. So we have a really rounded and robust problem statement. And I think we leave Mural now and go on to the next slide. And for those of us on the call, we might get a slide that we're going to skip past. No, we're great. So that gave us our starting point, our problem statement, so that we could move on to thinking about, well, where are our digital solutions? And it's over to you, Shazad.
Thanks, Tony. So yeah, as Tony and Liliana have explained really well, so we defined what the problem was. We understood exactly who's been affected, what the actual problem is, why we're doing it. And that problem statement was really fundamental to actually allowing a rich understanding. So then once we have that information available, we can then look at what the potential opportunities and options are in order to solve some of those digital challenges that we face, so the digital challenges that we're facing. So this is just currently what we're thinking of. And again, this is just some of the options that we're exploring. So do we put the information within the summary care record? That was something we're exploring. So in terms of valproate usage for women who of an age who can become pregnant, this is the kind of information that would be key for clinicians to be able to use. But again, just have to understand the limitations would be that it would just be for clinicians who have access. The other opportunity we were looking at is the potential use of NHS app. Again, this would be useful for the patients who are using the NHS app. I think there's a significant percentage of the country and the population which are using it now. So again, that's one avenue to explore. And again, another option was to potentially create a separate register. So these are the conversations which are ensuing at the moment, and these are the options which are being explored. So we capture in effect, from an informatics perspective, what the requirements are from the users. And in this case, it's clinical staff, the admin staff, the NHS, patients, etc. And then we translate them into capabilities within healthcare systems. So this is an ongoing project at the moment. So this is where we are, but we thought we'd kind of provide that feedback to yourselves. This has been a really useful journey for us all. And with that, I'll then hand over to Liliana. Next slide, please.
I think that's Tony.
Oh, sorry, beg your pardon.
It's okay. So just to reflect on what we had done, it was a really, really helpful experience from my point of view. But some of the things that we learned was that although it wasn't super long, it's not like we spent 15 months doing this, we did get it done quite quickly. But that's because we put quite a lot of time into the diary in order to do that. And it does take time to do each step well. I have to say that is time I do not regret spending, because I think the value of coming out with the visualization and the clear problem statement is well worth the effort of going through the process and doing it properly. One of the things that has really helped with this process was the fact that we have medication safety officers and myself and some of the others who had generally gone out to talk to the frontline clinicians and the problems and that they were facing in the management of valproate. This is what informed those patient stories, but it's not something that we could have done on our own. Otherwise, of course, what we would have ended up with is just a problem as imagined. And if you solve a problem that is imagined, then you get a solution that is completely based on imagination and not what people really need. And so it was really helpful to have that experience. At the end of the process, what we did was we went, actually, we do need to make sure that we have some sense checking of what we've designed. And so there's been a separate piece of work that we've been able to plug into to make sure that we are saying, this is what we've come up with in a blueprint, and these are the problem statements that we've designed. Does this feel like it reflects your position? And I'm very pleased to say that it has really helped to start us off with that process, but also helped us with the to get good quality feedback in a structured way. So listening to end users that have experience of the problem is absolutely critical. And the other element of this, which was really helpful, was picking those user stories to illustrate the pathway and what it's like in the real world. And I think it would have been very easy to go straight from the who, what, and where into the process map, but it would not have had the level of understanding and detail if it hadn't have been for focusing on those user stories. And then the last bit, and I'm always looking at this when we're thinking about how transferable is this piece of work to anywhere else. Liliana's skills, which she might not like me saying this, but Liliana's skills were absolutely crucial to this. Her ability to take words and visualize them in a flowchart was outstanding. In fact, it was almost like magic in the fact that she collected all the words, and then next time I saw her, we had a flow diagram that I looked at and went, yeah, that reflects my understanding of what's going on. And so this is not something that I think that will come naturally to everybody, but I do think having someone who can do that, taking words and visualizing, is a really important skill to have within this overall structured process. And now I hand on to Liliana, having just picked her up big time.
Well, I do have a quote from you, Tony, which is, it makes my day and it makes my month and probably my next years, which is the blueprint has allowed us to save to work in a problem and then 6 weeks ahead. So that was fantastic. And what I wanted to keep everybody in mind after this experience that we have together is how expertise together and could do many things. And by expertise, I mean you're an expert in your subject, and I'm an expert in my subject, which is user-centered design. And then to conclude, basically, so we use co-creation tools. We use the blueprint that allowed us to really see not only the process, but the pain points and the opportunities. The other thing that I take away from this work that we did together is I could see now how other members in the team, in the group, are actually using the tool and are learning to use the mapping and the way of visualizing their own ideas as well. And so that will be something that will be a last and long thing from this experience. That's it, I think. Thank you.
Thank you, Shazad, Liliana, and Tony for your great presentation. And it's great to really kind of see what the different expertise brings to the table in informatics, patient safety, and in user-centered design. So thank you. I know Sarah has asked if anyone has any questions around this presentation, if you'd like to pop them into the tab. I have been monitoring that whilst the presentation was going on, so I'll just turn to the panel and put some questions to you, if that's okay. So we had a question from James to ask, who drove the formation of the digital safety medicines and prescribing group, and how was or is it continuing to be facilitated?
So I'm happy to start with that, and might bring Tony in as well. But essentially, we've had discussions where in primary care there's a framework for any issues that arise that are related to digital challenges with regards to medicines. But in secondary care, there is usually with the suppliers that's been raised, and because that contracts directly with the NHS organisation, which is the Acute Care Trust, that's where the resolution usually occurs. But there have been challenges that may have occurred, or may have been misunderstandings of how functionality capability is available, where things get raised to the national level. So we thought there was an opportunity here to kind of collate some of those queries and challenges and to help facilitate their resolution. So hence, as Tony's mentioning in an earlier slide, we convened a group of people from digital medicines, from medicine safety officers, patient safety, and medication safety. Essentially, that's the reason why, but there's no contractual obligation as such at the moment. We're just looking to help facilitate that and to see what better opportunities are available in the future. Tony, do you want to say anything with that?
Yeah, so when that question came up, I was really actually who did form it, and actually I think it was a group of people who had similar desires to see things happen, and we came together by finding each other one at a time, and then realized that actually this was a structure that was missing in the organization to be able to look at digital solutions for medicine safety issues in a coordinated way. And so it was a group of impassioned volunteers who came together in order to make it happen. And I think as an improver, that's really important. You can form your groups in two ways. You can form your groups by going, oh right, well, I want representation from all organizations or all parts of the country, and and that does get good spread. Or you can form your groups by going, actually we just want people who are really, really interested and want to give up their time, probably their additional time, in order to do this piece of work. And it was very much a group of the latter.
Thank you, Shazad and Tony. I'll move. Hopefully that answers your question, James. I'll move on to the next one from Tina, which says, I'm an MSO and how can I be a support? I'm just wondering whether that needs reframing into what role did MSOs play in the group in this piece of work? And Tina, if I haven't articulated your question, please pop another one in. But I'm just wondering if that was the question, what role MSOs did play with the work that's been undertaken.
We did have a couple of MSOs that were on our group that did this piece of work, but we have a parallel piece of work, which is the Valporate Integrated Quality Improvement Program, that over the last year or so has included MSOs and other movers and shakers in Valporate in their local places. MSOs are pretty well populated in that group, simply because actually in many organizations the problem of the pregnancy prevention program has landed in the MSO's laps. It isn't particularly a pharmacy issue, it's an everybody issue, as we've described in the complex patient pathway. But as is the way with so many of these things, if there's a medicine in the pathway, then it comes to pharmacists to solve. So there's quite a few MSOs who have been involved, and when I did my appreciative inquiry going around places that said that they were looking at ways to improve the pregnancy prevention program, MSOs were frequently in the group of people who I spoke to there. And now we have a collective of people who are active in Valporate who are trying to implement the MHRA alert at the moment, that was issued at the end of November, and we're supporting those people with task and finish groups and opportunities to share and learn. I'm going to put the chat, the future site for the Medicine Safety Improvement Program, which includes Valporate, in the chat now. And I'll also put a contact email in the chat for anybody who does want to play an active part in trying to move us forward with these solutions, either in the clinical solutions or in these digital solutions, which I think will genuinely transform the way we manage Valporate over the next few years.
Thank you, Tony, and I thank you, Tina, again for just following up your comment to say that I've asked the question in the way you do. I hope so. I appreciate that. So I'm hoping that's answered your question, and thank you, Tony, for offering to put those links in. I'll move on to the next question, which has come from Sam, asking, how did you find the using of the app Mural? I'm sure that's for any one of you.
Liliana, would you like to go first? Because I'm conscious you haven't had a chance to speak yet.
Yes, I could actually mention some things. Miro and Mural and all of those tools that can facilitate the work between many people and teams, etc. They're very useful, but there's a learning curve of knowledge. So then sometimes at the beginning they could be quite challenging. I know some people actually struggle all the time actually to get in, or really don't understand how visualization really help. So then you always have to have other tools that are under your sleeve. For example, you could actually do some things in Word. If you think Mural is not the right sort of tool for you, you could even use PowerPoint to actually, sketch your ideas, etc. I know that was not your question, but I'm actually giving you examples of that. So it sometimes could be very challenging, but when you actually have a tool that really facilitates and everybody is on board in learning, as I said, it could be a challenge for some people to learn how to use it. But when you just learn the basics and then you understand that not everybody is capable of doing everything, then it's a great tool to help us all work together. So I don't know if that answered completely your question, and I give you a couple of other things to talk.
That's great, Liliana. Thanks. I've got something I'm probably going to add, but Tony, I'd be keen to understand what your thoughts were as well.
So we frequently use online tools in order to do workshops, and so the idea of contributing to a group platform that everybody's contributing to at the same time, that was pretty familiar. This particular system, I couldn't have made it look as beautiful as Liliana did, not without many hours of constructed learning, and that would have stopped me from using it if I didn't have the skills in the team that we pulled together. So from that point of view, it's a great tool. The structure, of course, is not unique to Mural, and the design process that we were taken through could be on any platform, and so it's distinct from the platform. In order to collaborate, fantastic, Mural did a good job. It was really easy to use from that point of view. The understanding of how to go from the problem in our heads to a fantastically described problem statement in words on paper, then that's how the structure was put on top of Mural. But using it as a platform to collaborate on, that was really easy. It really is just a case of produce your sticky note and write some words in the smallest space you possibly can on the Mural board.
Thanks, Tony. Yeah, I'd probably echo those sentiments. So essentially, there's a number of tools, as my colleagues have just mentioned. I think this is the time to put a disclaimer in. When someone talks about going to one shop or another and they just say all the shops are available, there are the tools available. So what we've used is Mural, and I think Liliana mentioned another one. But in terms of working remotely, like I think Liliana and I have met once in the office recently, and that was about it. But this just helps us, from people who work in different areas across the country, collaborate in a workshop environment. And as Tony and Liliana were mentioning earlier, there was quite a few of these workshops that we had, and we had to take a vote on who needs to be involved, who are the priority, what is the main problem here. Is it getting information to the clinicians? Is it getting information to the patients? Is it about pregnancy prevention? So yeah, it's finding out what the issues are, and then also voting on what is the most the biggest priority. So that's really useful. This tool does that really well. And then again, being able to put all those ideas down and having that framework available, there are opportunities there within that tool to do that. But I think, again, this boils down to, no matter how good the tools are, it depends on how good the people are. So Tony was really good and instrumental in actually bringing this issue to us and being able to articulate it really well, and for us to bombard him with questions, and he would have a lot of answers, but there are occasions where you say, well, I'm not sure. And so that's where we were able to go out and find out that information. But furthermore, the rest of the team, I think we need to give them a big shout as well, in terms of Graham, Rahul, and the rest of Chris, and the rest of the team as well. They've all been really, really thorough in understanding who's been involved, what the problem is as well. So I think this is where it's just not also down to the tool, but also down to the people who use it. And then Liliana bringing us together and being able to bring our ideas and to actually display it is really beneficial. And hopefully the way we've approached this, if there's anything similar in the future which arises, then we'll be able to take a similar format. Thanks, and back over to you, Paul. Thank
you all for your answers, and I see Sam has also put just a follow up to say thank you, particularly to Lily, that they did answer the question, but obviously for all of your comments. So I think we've covered Sam's point well there. Thank you. I'm going to move on to the next question, which is from Johanna or Johanna. Apologies if I've not pronounced that right. So the question is, do you have a time frame in mind for when the digital solution will be available? We have been looking at building ARAF and MRAF into our ePMA system, but this would seem a poor use of resource if a national digital solution will be available.
So I think it's very unlikely that we'll move towards a national standalone registry, and that is because the number of users who would have to have unique access is just absolutely daunting. From when we're thinking about people who are essentially using their acute trust systems to record their ARAF, this is fantastic work. There are a lot of acute trust systems. What we're going to try and pursue first is how to use summary care record in a more efficient way, because everybody has access to it, or at least the vast majority of people have access to it. And all the SNOMED codes that we could possibly want are already available. And so what we'll probably do is we'll probably get better and better at using digital solutions over time. I'd really like to see summary care record in play by the end of this financial year. That might be ambitious. I don't know. I don't have to create the stuff. But that I think would make a massive difference, whilst we then work up some other solutions. But yeah, timeframes wise, I'm really rubbish at that. I can't even tell, whether or not I did something this week, last week, or the week before. So estimating future time, I'm really struggle with. Personal failing.
I'm just going to come in at this point. I don't think that's a reflection on you, Tony. I think your timekeeping has been immaculate in the work we've done so far, because I think you've kept us on point. But what I will say is that in terms of being able to provide that timeline, you're right, we can't do that right now, because there's no national solution available right now. But obviously, if we're going to do a national solution, that's what we're trying to do, trying to create a digital solution that's beneficial for everyone. We have to make sure we consult with the right people, look at what opportunities are available. And so I think we're not in that position yet, because we're having those initial discussions. And this is why we thought it'd be really useful just to kind of show this is a problem that's only come to us recently, it's in the news, and how we're actually trying to get ahead of the game. So this was then again raised to Tony, I think, at the beginning of January, if I remember, Tony. And then that's when you said, actually, because we've done this work beforehand, it's actually saved us 6 weeks of work that now that they're asking for this question to be this resolution. So I think in that sense, you can give yourself a big pat on the back for actually getting ahead of the game and preempting what could come. But then secondly, Paul, just who was it, the person that raised the question?
Johanna or Johanna, sorry. Yeah.
So yeah, the person who raised that, I think that's, if you could potentially reach out to us as well, I think that'd be really, really useful for us to understand how you were looking to implement that form. And rest assured that would not be a waste of time, because whatever solution you're using, if you could replicate that, and we can help to have those discussions and how that can be replicated and what other opportunities there are, not just for your solution, but then potentially for others as well. I think that'd be really key, because there's innovation that we do at the center to try and help to resolve some of these digital challenges, but there's also each and every single team out there and individual out there who's working in this informatics environment. Them to provide those solutions, believe me, that can be so beneficial to people across the board. I remember we did something for Cerner that hadn't been done, had been done, and Cerner was around for a number of years, and that was then beneficial for others as well. So I'm sure that R form, you guys are already ahead of the curve. That's great to see, and we're really keen on understanding how you've gone about that, or what that entails. Thanks.
Thanks, Yazad. Just looking at the time that we we have 10 minutes left, running up to 2 o'clock. Probably got about 5 or so questions left to run through. But obviously, if we don't get to any today, then we'll take note of them and get answers back to people. But I'll move on then. So question from Chris. Really interesting to see how the process. Really interesting to see the process to really define the problem. How do you see that you can take this learning and can cascade the information out into all the areas that need to be aware of the problem?
Liliana, do you want to take that one?
Yes. I mean, the opportunities are various, and there are different sort of things that we could really do. So then what I will propose, for example, is take some of them and then create a design process with some of them. Will be really good to see if the digital tool can be something that can be developed for there. We could actually think as well in the how can we actually work with GPs as well and the specialists and see if there is something they already do, for example. So then we could do a little bit of user research over there, and if they already are doing something, then how can we actually incorporate that knowledge as well within the issue that we have in hand. Yeah, I would say that. So then the next steps are more design, I would say. Use more the design tool.
Thank you, Lily. I think that may also cover off some other questions as well that we had. Was fascinating process and presentation. Thank you. What next steps are there and how the service design could input into it? And then Chris also asked, how do you think that user-centered design and service design techniques can help with the next steps of the process? So I think you will have answered that, Liliana, unless you have anything else you want to come back on to add to that. I'll move on to the next question from Eileen, which is, just wondering if you included charities, MSOs from mental health trusts and social care providers in your review, and have you considered those who are digitally excluded, such as homeless and travelling communities and learning disability patients? Some of the English heat map data suggests that there is higher percentage of patients in coastal, more deprived communities. Has geographical location been considered?
That is a great question. It's a great question because actually, yes, we did consider the geographical boundaries, the geographical variation. One of the things that came through from the appreciative inquiry was that that the people who were providing the structure for pregnancy prevention program felt most uncomfortable that they were definitely meeting the needs of patients with learning disability, patients with language barriers, patients with dual diagnosis of bipolar and epilepsy, and patients in the lowest demographic IMD profiles. And this really gave us a focus for when we're thinking about the patient stories that we were talking about earlier, how to build that into those patient stories. Learning disability is something that I think is quite profound here. There's patients with epilepsy have a higher incidence of learning disability, and vice versa when it comes to their condition. So that's a patient group that we really need to focus on, and we generally do think that if we can get it right for the patients with learning disability, we can get it right for everybody. So that's a great question. Also, the question about charities. So the charities are really, really active in this space, and so most of the work that has been gone on with the charities has happened at national level, particularly with the MHRA, who have done a huge amount of consultation with the charities and taken quite a lot of, I'll call it, feedback from the charities on how to get these systems right. And were MSOs in mental health trusts involved, actually, I would have said that MSOs in mental health trusts were at the forefront of what is possible digitally, with finding some fantastic local solutions for keeping track of patients who are on their books. So rather than including them as an afterthought, they were actually at the front of this.
Thank you, Thank you, Tony. That's great. I'll just get it through. I think we might have one or two last questions. Liz asks, how do you access blueprint tools for clinical informatics?
That's a really good question. I'm going to find the link for the Services Design Network. Is one of the most typical tools, and then it's available for everybody. But there are more if you just Google it, blueprint for Services Design Blueprint. You'll get quite a few ways of doing it, and templates and everything. So also, if you have access to Mural, if you have access to Miro, they have templates as well for blueprints and user journeys as well. So you could actually do that, Google it through user journeys as well. And find the one for the Services Design Network, and I'm going to put it in the chat.
Thank you, Lily. Last question I'll go to then is from Lloyd. He says, although there won't be a national digital solution available, are there discussions shared with the EPR providers, Epic, Nervecenter, Oracle Health, as he's given as examples, surely have an obligation to make sure their clients have workable solutions available rather than every trust configuring their first thing? Shazad, do you have any insight into that or anything around user groups of system suppliers?
Yeah, so we haven't actually personally gone out to anyone as yet from the large suppliers. So as we said earlier, this is very much hot off the press. So I think that those are some of the options available to us, and hence why, if it's Johanna or Johanna earlier that was mentioning they'd already started to think of it. I think that's kind of what we hoped, is that when these issues arise within secondary care, then it's incumbent upon those users within secondary care, those organizations, to speak to suppliers. And obviously from the central team, we'll obviously advocate doing that and trying to do that ourselves. But because it's a little bit trickier, because we don't have the direct contract, the actual customer user relationship is with the trusts. Inevitably, there will be discussions that hopefully will take place, but from a national solution, it's been more primary care focused. But Tony, I don't know if you've heard anything different.
No, I know it's one of the things that Rahul really wants to see us have in place is a forum for those large providers to come together so that we can have dialogue. Because as the questioner points out, if they don't know what problems we need solving, they can't go about solving them for us. And so, but currently that forum doesn't exist, and so the power is really with the service user to try and raise this. And the more service users that raise it, then the more we would like it to think that it bumps up the design agenda of the providers.
Yeah, exactly. And a lot of those conversations will take place either within user groups or directly from the trust, who identify that there's certain clinical safety issues that need to be resolved or have digital solutions available. But again, we just welcome conversation, and this is part of having this ePrescribing Masterclass, is to stimulate such a conversation to ensure we have the ability to overcome some of these challenges and to find and facilitate better capabilities within the systems. Because inevitably, system suppliers will have a lot of priorities on their plate at the moment, whether it's to go out to new customers, to make sure that existing implementations are done correctly and optimized correctly as well. Furthermore, there's also about new functionality. Do you deal with in terms of diabetes? You don't deal in terms of microbial stewardship, parental nutrition, heparin, etc. So which is a priority? So that's defined by us as a collective. So the more voices that are part of this conversation, the better.
Thank you, Shazad. Thank you to all of you for helping answer the questions that people have put forward, and thank you to everyone who did put questions. There's some really good ones in there to generate conversation. Sarah, if we can move on to just the closing remarks and the last slide, please, as we close off today's session. Thank you everyone again for joining. I hope you found that really useful. The next Masterclass session will be in April. It's a little later on in April due to holidays and things. It's on Wednesday the 17th, but at the normal time of 1 till 2. we'd love to hear from you as to whether there's anyone out there who would like to present on a future masterclass, or who has any topics of conversation that they would like to see. Please get in touch with us. And as Shazad mentioned at the start of the session around the community of practice that I've mentioned, I will pop the link into the future NHS page so that people can see that what we're talking about here, the community of practice, which people should have access to, having been a member through the masterclass, where these kind of conversations and questions can be raised in discussion boards. So if you go on there, if you go on the link that I've sent you, that'll take you through to community, and we've set up a number of different forums which you can pose questions in for the group to answer, or if there are particular forums that you would like to see set up, then please contact us and we can look to add forums if there isn't anything particularly suitable. But it's 1 minute past 2 now, so we are at the end of the session. Shazad, do you want to have any closing remarks? And I'll finish there, and just to thank everyone.
Yeah, no, I agree. Just want to reiterate thanks to Tony and Liliana for stepping in last minute. And people won't realize this has actually been done, all the presentation been done in most of the last week or so. So thanks to them. Thanks, Paul, to organizing it. And also thank you to Sarah and Abby, who've been instrumental in making sure that we're on point and navigating back and forth between Mural and PowerPoint. So thank you very much for organizing us. Very much appreciated. And the last remarks I'd like to make is, it's been great to see the engagement today. Really, really, Paul and I would encourage, as we said before, get involved, ask questions, let us know what you want to hear about. And also, if you want to present, we'd love to hear from you as well and share this information. So thank you very much, everyone.
Thank you, everyone.
Thank you.